So good afternoon, my name is Caroline, and today I would like to tell you the story of Paul, 52 years old. It was Sunday, and as many of us, Paul was enjoying a precious family moment. But suddenly, he felt a very strong pain in the chest and fell unconscious on the floor. 1 hour later, Paul was admitted to hospital with a massive heart attack. Unfortunately, his condition rapidly worsened with a severe cardiogenic collapse. So the cardiologist decided to initiate an extracorporeal membrane oxygenation supply. This supply, also known as ECMO, is a powerful but very complex system, as you can perfectly see on this picture. It uses pumps to circulate and oxygenize blood when heart is no longer working. This supply allows pending for cardiac function recovery or bridge to a ventricular assist device or even cardiac transplantation. However, blood exposure to non-physiological surfaces induces major haemostatic changes such as strong activation of coagulation and platelets. Therefore, to maintain patency of ECMO circuits and therefore to reduce the risk of thrombosis, an antithrombotic therapy is systematically used, and to achieve this goal, unfractionated heparin is therefore always used. But the use of unfractionated heparin exposes patients to a risk of heparin-induced thrombocytopenia. This immune complication, also known as HIT or HIT, is due to the presence of antibodies directed against a platelet protein, which is called PF4. This tetrameric protein, which curiously looks like pétanque balls, very famous in Marseille, is able to interact with heparin, thus leading to the development of IgG antibodies directed against platelet factor 4 modified by heparin. Pathogenic antibodies are able to bind blood cells, including platelets, leading to multicellular activation and hypercoagulability state, which is responsible for the occurrence in patients of thrombotic events in approximately 50% of them. Now let's go back to the story of Paul. As you can perfectly see on this graph, which represents platelet count evolution during ECMO, Paul rapidly experienced a platelet count fall. It was present since the initiation of ECMO and even worsened after day 5. This thrombocytopenia could possibly result from different causes, such as platelet consumption within the device itself, sepsis, hemodilution, but it could also result from a drug-related side effect, and in this context, heparin was a good potential candidate. However, when we questioned about the frequency of immunization against platelet factor 4 and even of HIT during this particular clinical setting, data available were very unclear. And this prompted us to initiate a prospective study, and we then collected samples from 57 patients. These patients all had underwent veno-arterial ECMO for at least 5 days in the cardiovascular surgery unit of a hospital. Apart from collecting data, we also analyzed carefully clinical history and evolution of all patients. So here are balloons, blue balloons. I really love balloons. And on this slide, they represent PF4 specific antibodies. And we were very interested to observe that 50% of patients developed PF4 specific antibodies during ECMO, which is very frequent, with IgG isotypes present in 30% of them. However, these antibodies were potentially pathogenic in only 3 patients who displayed a positive serotonin release assay, which is the gold standard test to assess the pathogenicity of such antibodies during HIT. And you must notice that these patients developed relatively high titers of PF4 specific antibodies with an absorbance higher than 1.5 units in the 3 cases. Okay, so now let me introduce you my boss that you must recognize, Professor Gruel. It looks good on the screen. And as you can perfectly see, he really enjoys cycling. But these 2 curves do not represent his next ambitious trip, I hope so, but the platelet count evolution during ECMO of both immunized patients in red and non-immunized patients in blue. And as you can perfectly see, platelet count evolution during ECMO was very similar whether patients had developed PF4 specific antibodies or not. Indeed, platelet count fall rapidly since the initiation of ECMO until days 5, 6, and then slowly recovered for reaching the pre-ECMO value approximately 1 week later. During the time of our study, HIT was suspected in 2 patients. One who experienced an exacerbation of his platelet count fall after day 5 or 6 of ECMO. Bye-bye. And the second one, who is now perfectly interpreted by my second boss, Professor Claire Pouplat. This patient displayed a similar PC pattern, but a little bit later, with a platelet count fall, a second platelet count fall occurring after day 10. Interestingly, the 2 patients developed high titers of PF4 specific antibodies, and their pathogenicity was confirmed using the serotonin release assay. So in this context, heparin was rapidly replaced by agatroban, which is a powerful direct thrombin inhibitor, and it was followed by a platelet count recovery a few days later. Now let's go back again to the story of Paul. Paul's thrombocytopenia could possibly result from HIT. It was logical to think of HIT since he exhibited an exacerbation of his platelet count fall on day 6 of ECMO. But Paul's thrombocytopenia was rather attributed to a severe pneumonia, and an antibiotic therapy was initiated on day 6 of ECMO. But unfortunately, on day 8, an extended clotting of ECMO circuits was observed. Then circuits were replaced, but it was followed on day 9 by a massive pulmonary embolism. And unfortunately, Paul died a few hours later on day 10. HIT was suspected a posteriori on day 10, and it was confirmed by the detection of high titers of PF4 specific antibodies, which were pathogenic using the serotonin release assay. So what are the key messages you have to keep in mind in clinical practice? First, even if thrombocytopenia is very frequent during ECMO, you should always think of HIT in patients experiencing a platelet count fall after day 5 or even a non-recovery of platelet count after this time. Secondly, you should always confirm HIT by looking for PF4 specific antibodies and by confirming their pathogenicity using a functional test such as the serotonin release assay. And this second point is very important, since I showed you before that the majority of antibodies developed during ECMO were non-pathogenic. Thank you for your attention, and I also thank my 2 supervisors for their constant support.